Willow Creek Springs presents Healthy Living with your host, Joe Grumbine.
Well, hello and welcome back to the Healthy Living Podcast. I'm your host, Joe Grumbine, and today we have back with us Dr. Robert Hoffman. Robert, welcome back to the show. How are you doing today?
Glad to be on this show.
Well, we have our weekly meeting that I talk about all the time and the importance of it. And we have a new patient that's been joining us, and she's got a pretty serious situation. She's got a metastasized breast cancer that is, you know, changing. And we were talking about how she got some tests, lab reports, and all of a sudden the numbers that she used to be looking at are fine, but a new number changed. And I want to talk a little bit about cancer and its ability to change and sort of you end up like people think you just go and get treated, and it's not that. You engage and you have to find an answer, but when you find that answer, you don't stop. You have to keep finding an answer, and you have to keep checking, and you have to keep looking for anything different. And I don't think people realize, especially the people that like just go to the doctor and do what they say. What's your thoughts on the approach of, the people that just go to the oncologist and they get their diagnosis and they say, well, here's what we're going to do. And they say, okay, doctor, I'll do what you say, as opposed to, being aggressive and trying everything you can to find out everything you can.
Well, Joe, the very fact that some of your cells turn into cancer cells and made a tumor means they made a very big change. Very big. So the cells having become cancerous, they don't stop changing. Otherwise, they couldn't have become a cancer, which is a huge change from what it used to be. So
maybe people don't realize that like you don't catch cancer like a virus. You don't get cancer from, inhaling something or touching somebody. It's your own body, like you just said, going through tremendous amount of changes, and it starts out with maybe a few cells that do this, and usually like your immune system recognizes troubled cells that aren't behaving correctly and takes them out, but they don't always. And the cancer cloaks itself sometimes.
you think about a human body over a lifetime. It goes through about 10 and 16 zeros cell divisions.
Wow.
16 zeros after the 10.
Wow.
So, and
a billion is what, like 8?
yeah, it's a billion, whatever it is.
Wow.
And so genes mutate about every 10 with 6 zeros divisions.
Okay.
So that means every gene in your body is probably mutating 10 with 10 zeros during your lifetime. Wow.
That's a lot of mutation, yeah.
So I think you're right. Probably the immune system is surveying them and keeping them out, or they mutated cells die. So these people who come out and say, oh, cancer is due to genetic mutation, they don't know how to do the 9th grade arithmetic. So something very significant took place that overcomes all the body's resistance where it can undergo 10 and 16 zeros cell divisions. I don't even know what you call that number.
It's a big number. That's for sure.
It's one heck of a big number. So this cancer faked out the body that could handle 10 to the 16 cell divisions and probably 10 with 10 zeros mutations in every gene. So what is that? It's some new form of life in your body that can undergo extremely significant change to become a cancer cell that grows when it shouldn't grow, often grows faster than it should, not always, and doesn't stay where it should stay very often. That's called metastasis. So this cancer, this monster, has undergone something so big change that your body, which can handle everything, can't handle it. So is that cancer going to stop changing? Oh, I diagnosed you. I got diagnosed. I'm not going to change anymore. Way.
Yeah.
It's going to keep changing. And what we do, and then you get probably all kinds of different variations on the theme, and then you got to really watch out. So, like one of our patients, Chihiro, she was taking this drug for 3 years and doing good. And all of a sudden, the cancer exploded. Why is that? Probably the drug was keeping out all the cells that were sensitive to it, but some cells, cancer cells, because they can change so readily, said, hey, wait a minute, I'm going to figure out how to get around this drug. And they started multiplying and multiplying and multiplying. All of a sudden, her cancer exploded. 3 years, flat for her marker, and then boom. Why? Because the cancer underwent another change, and the drug was selecting against the cells that were sensitive, and these guys figured out how to get around the drug, and in so doing, often, maybe most of the time, we don't know, but enough of the time, when the cancer cell becomes resistant to a drug for reasons that aren't clear yet, a little bit clear, they become more malignant. Not always, but that can happen way too often. The drug-resistant cell, when the patient so-called recurs, which is a misnomer, didn't recur, it's regrew. And when that happens, they meet their demise very quickly, very often after the so-called recurrence, because those cells have been they work their way around to overcome the drug or drugs, and in so doing, they became more malignant. So
Now,
drug resistance is bad. Recurrence is bad. So we got to work. We have to, as I say all the time on the Zoom, we have to stay ahead of the cancer to prevent that happening.
exactly. Now, with Shahiro's case, and I think with Dr. Exume's case and a couple of others, maybe even Gene, these are all people that have been very rigorously on the low methionine diet and taking methionase. So that's what's most troubling to me is that do you think the cancer is finding a way around its methionine dependence as well?
No. So if the cancer becomes methionine independent, directly opposite to what happens with the cancer becomes drug resistant, when the cancer becomes methionine independent, and rarely so, it loses its malignancy. We are, Joe, we're not completely restricting methionine.
Right, that's true.
So we're only partially doing it. We're taking oral enzyme. We're watching our diet. It's not like having a dish of cells and you take all the methionine out. No, this is the
Right.
human body. The liver is pumping out methionine. So we're only partially restricting methionine, and that's a good thing. But it's
Mhm.
in most cases, we need help.
Right.
We need a good drug or a good immunotherapy. We need help. We can't just do that.
Right. Right.
That's too naive. So when we choose the drug to help us out, do we want to keep using that drug for 3 years like Chihiro and let all these monsters start learning how to overcome the drug? No. So so I think we have to learn more about the so-called adaptive therapy,
Mm-hmm.
where you put the drug in, take it out, put it in, take it out, so that you don't have the drug consistently applied and letting the bad guys finally take over. So you kind of have to let the less bad guys maybe grow a little bit and compete out the more bad guys, because the more bad guys need more energy to grow because they're doing more things to become resistant. So there's something to say about treat, get off the treatment, treat, get off the treatment. That does not apply to methionine restriction.
Got
Methionine
it.
restriction, you stop, the cells start growing again. So we need to stay ahead. How we do this, we're in the new zone here, Joe. The usual guideline oncologist this is way over their head,
Oh yeah.
way over their head.
It's too much work too.
Huh?
It's too much work for most of them.
Too much work and too much brain power that's required. These
Right.
guideline oncologists have their guidebook. Okay, you got this. Here's first line. Oh, you failed that. Here's second line. Oh, you failed that. Here's your clinical trial. Oh, you failed that. Okay, hospice. Uh,
Right.
so these guys treating the patients have very limited education. And I'm sorry to say, I think many of them they're not Einstein. Let's put it that way. So uh, we have to stay ahead of the cancer. And how do we do that? I mean, one way is to surely not stay on the same drug for a long time. Oh, it's working, it's working, it's working. And then you wake up one day, it's not working,
Right.
and you're in big trouble. So we don't want that. So we need to change out and maybe come back, change, come back. There's a lot of drugs out there, and also the gene tests may help. We try to find genes that may help. We look for the circulating cancer cells, they may help, or even the circulating cancer DNA, that may help. The more tests, the better.
Yeah, I think that's critical because in some cases, like with breast cancer, I've heard of this a lot where they'll do whatever their first line is. Maybe it's surgery, maybe it's radiation, maybe chemo, maybe some combination, and they say it's gone. They've tested for it, it's gone. And then weeks, months, or years later, it'll come back somewhere else and it'll be different.
Breast cancer is the worst in
Yeah,
that way. It can stay dormant for decades,
yeah,
hiding. And all of a sudden, maybe some bad guy cell finally takes over. It took them 20, 30 years to do it, but finally they do it. And so breast cancer is the most sneaky of all the cancers. The most, oh yeah, I'm cured, sure, yeah. First of all, nobody's ever cured, in my opinion. You get cancer, you have to be diligent. Whatever you got, you overcame the body's ability to go through 10 with 16 zero cell divisions and hang. It overcame that kind of environment where the body is super protecting itself, and it got around that. So cancer is nothing to play with. It's always dangerous. Even when the bet best, like yourself, the best screening in the world, methionine PET, you're negative. You have to stay diligent all your life, because even the best screening, probably the minimum number of cells it can see is a few million.
Right, right.
So that's where we are, Joe. A lot of times we're fighting an enemy we can't see, but we assume it's there, and that's a good thing. I think everybody should be on methionine restriction. I think that's a no-brainer. That's just a good, healthy lifestyle, and cancers sure don't like it.
Oh, I
We
agree.
gotta stay ahead. I mean, the champion at staying ahead is Dr. Exame.
Yeah.
He stayed ahead of stage 4 lung cancer for 5 years, and he's still doing it. But he's got 13 metastases in his brain. He's going to get a port on his head for the brain.
Really?
He's kind of leading the world and teaching us how to stay ahead of a cancer.
Now, a question about that. What would the purpose of the port in his brain?
To get the brain to get into the vessels that feed the brain.
They're going to deliver the medicine right there.
It's got chemo in it to get those brain metastases.
Wow.
13
Wow.
brain metastases.
So they can get it right into where it's at and leave the
rest. Hopefully, I think so. This is way beyond my expertise, but I hope so.
Wow. Wow. All right. I never heard of that before.
He's staying ahead. He's not playing whack-a-mole. He's
No.
ahead.
Hi, this is Joe Grumbine, and I wanted to share an update. The platform that hosts this podcast has made some changes to the subscriber settings, and we have a number of subscriber-only episodes that we offer to the supporters, and for a minimum of $3 a month, we can get you signed up. And if you're already signed up and you're having some kind of trouble locating these episodes in the other platforms, I would say maybe the best answer is to unsubscribe and then resubscribe. I'm sorry for the hassle. I don't have any way to make a change, but I'm very grateful for all the support. Thank you.
Yeah, and I think that's critical. So are there, I mean, I know that each different type of cancer, there are certain tests that can show you markers that excuse me, would apply to that cancer. Different antigens and different things that the body creates when the cancer is present. But are there, aside from a PET CT or the methionine PET, are there any kind of screens that are kind of just a general, is there any kind of a malignant mutation present? Is there anything that you can do on that note?
I don't know if any universal marker. Each cancer seems to have a marker that it predominates, but it could be kind of a submarker to other cancers. That's all good. I don't know how universal it is to have circulating cancer cells or circulating cancer DNA that came from those cells. Those are good things to capture. We have ways to capture them and analyze their genes.
Well, I guess
they're going to be very helpful.
for my purpose,
they're not what you're asking for, but
right,
it's more than they used to be.
So for my purpose, I had squamous cell carcinoma that has a specific antigen marker that I was able to test for. It came out negative right about the same time I got the met PET. But the cancer that I had was HPV driven, so it also showed a spike in that
At least
viral.
HPV associated.
Okay, got it. HPV associated. So I had HPV virus. The cancer seemed to be somehow caused by it, and but that was in
So
my
I
favor.
got to take this. Can you cut off just for a minute?
Absolutely, absolutely. All right, so we're back. So, like I was saying, I had this squamous cell carcinoma. I had a couple of tests that I was able to do that indicated certain things. Like they did initially this viral test that indicated the presence of this virus on a huge level. And then once I got going with the chemo, that was gone. But the cancer was still there. But at least it gave me some indicator that the thing that likely is causing it, or at least contributing to it a lot, wasn't there anymore. And then most recently, I had that SCCA, the antigen test that was looking for circulating tumor cells, and it didn't find any of that. So the question is, though, in a year, I'm going to go back and get a Met PET. Aside from a PET CT or a Met PET, I mean, what if it was to come back? The odds are it wouldn't come back the same way it came the first time, right?
It can come back anyway.
Exactly. That's what I'm saying. It could do anything.
It could come back in the primary site. It could come back as a metastasis.
Exactly.
We don't know.
We don't know. Exactly. So I'm looking at, obviously, my life choices are going to be probably the biggest determining factor in keeping it gone, keeping the diet strong, keeping the methionase in my presence, the oxygen therapies. I'm getting back into the ivermectin and the the sodium bicarbonate and a few other things. But aside from those things, you can do things preventatively and, live the healthiest life you can, the the least cancer friendly life, I guess you could call it. But then the other side of it is like, I don't want to live my life thinking, oh, I better check tomorrow. I better check tomorrow because, that starts getting under your skin. Is there some kind of a regimen we could look at that would say, all right, if you follow along this way, like you're saying, my biggest issue is that these tests only light up when you're already down the road. I mean, you're not getting this, you're not finding out anything at a real early stage.
Well, the type of cancer you have doesn't really have a universal marker.
Right?
So you need to get periodic imaging, Joe.
Yeah.
And maybe the Met PET once a year, but the other stuff, MRI or CT, glucose PET, I would try for every 3 months.
Yeah. Okay. Fair enough.
I mean, I don't know if the insurance, these are things you can work out with Dr. Song.
Exactly.
He's so good at getting insurance.
You know what I noticed with him? Remember originally when I was sitting with Dr. Castro and he had ordered a piece of the tumor to go to the lab in Boston to get the genetic work done? My insurance rejected it. Well, Dr. Song somehow got that same genetic test done. I don't know if it was from the same lab or not, but insurance took it and I didn't get billed. So
Well, they're
Dr. Song,
different. Some are really different. Maybe
yeah,
Castro's looks at many thousands of genes.
that's possible too.
I think his one is like the super test
Got it.
and maybe super expensive. And there's look at 20 genes and it's quite different.
Okay. Fair enough.
I don't know this, but I'm guessing.
Yeah, yeah. Okay. But there isn't like, okay, so they found these genetic markers from the tumor that I had, but that's really irrelevant today, right? Like there's not.
Partly relevant. I think a good part of them are probably conserved, but you have to assume there's going to be some new ones and maybe some that disappear. I don't know. I can't answer it. Other
Yeah.
than say I think what you should maybe assume.
Yeah, absolutely. And I'm having this conversation for all the people that have gotten themselves to a part where they think that they have it resolved or it's resolved for the moment. And try to lay out a pathway. The first pathway was to get it gone. All right. So we found that. We navigated, we did the hard work, we did everything we could and we got the results. Now it's a different target. It's one thing to take something that you can see and make it go away. It's another thing to take something you can't see and keep it gone. And that's
Yeah.
maybe even more
Oh,
difficult.
it's tough, Joe. It's tough. The best advice I have is periodic imaging.
Yeah,
Surely you want to talk about this to Dr. Song.
right.
I'm really pleased that he continues to give you Keytruda.
Yeah,
Hopefully that'll continue longer.
right. It
Maybe.
sounds like he wants to do it for at least another through the next year, is what he was talking about. So,
Ooh, that's so good, Joe.
yeah. So I'm looking at that and it's hard to say. It's one thing to take a drug and be able to see a result. It's another thing to take something like this immunotherapy and say, well, I don't feel any different, but that's good. That means I don't have,
Well, you don't know. I mean, the fact that you tolerate it so
right.
well
Yeah,
is a big plus. If it's, we don't know if it's working or not, but it
right.
has a chance to be working, and you tolerate it so you can keep taking it. So all of
Exactly.
that is good.
Yeah. And he's
All
got
good.
the insurance paying for it, which is even better.
Absolutely. Your song.
Yeah, yeah. So,
He's been in the business half a century. He knows how to deal with those insurance companies.
well, and that's another godsend. Well, none of the other doctors that I dealt with would even make an attempt at anything difficult with that. They just say, they're not going to cover it, and wouldn't even put an effort in. Now we were talking last meeting, and I'm going to continually reference these meetings because you know I'm watching this new person, Kat, come in, and she's got a very difficult situation that she's dealing with, and she just did some blood work. She's going to Dr. Castro, and
I want to interject there a little bit, Joe.
yeah,
She's comparing tests from two different labs. That's
I
a no,
agree. Right, right.
the no.
Yeah,
So we need to settle down in a lab
right,
and compare over a few months, weeks, whatever, in the same lab.
right.
And I, for somebody like her who has all this cancer and has to deal with it, I would want my test in a big lab,
Yeah,
not
fair enough. She
not the
was in-house.
doctor's back office lab. That
Was in-house. Yeah.
I, that's, I mean, I don't know. That's
No,
not
that
that
makes
the doctor's
sense.
back office lab can't do it, but the professional labs have the incredible automated machines that they have to keep tuned.
Hmm. And they're doing so many of them.
Millions,
They've got
millions,
the
millions.
experience. Yeah, big time.
Yeah, yeah.
Well,
Not like the part-time nurse in the
right.
doctor's office. It's different.
Yeah, I agree.
I don't know. We'll see what the girl does. She's very smart. Let's see.
Well, I know that, for example, when I go in to see Dr. Song, initially he was doing it a lot. He's not doing it so much anymore, but he would take a sample of my blood before I do the infusion, and they were checking for certain markers to see if I was okay to do the infusion because the drugs were really difficult. So they were checking my blood cell count and certain things that would say if they were off the chart, they wouldn't give me the infusion.
Where was this show?
Oh, no, with Dr. Song.
Okay.
Okay, so when I get there, They weigh me, they check my vitals, and they pull a little blood, and they do an in-house test. That's a very rudimentary test. They go at glucose level,
They
red
just want
blood.
to make sure you're alive.
Exactly, and then that I'm okay to take that infusion. But many cases, as soon as I go to get the infusion, Dr. Sung will pull a big old vial or two of blood, and he'll send that off to the lab, to Quest or one of the other labs, and then they come back in a couple of days with a complete panel.
Yeah.
And I've noticed that some of the things they're testing for are identical, and the numbers aren't identical. So I'd say to myself, all right, well, I'm going to probably feel a little more comfortable with the big labs numbers just for that reason that you were talking about. And it was never anything that far out of range, but they weren't identical. And so that I see where you're coming from with that. One of the things we were talking about recently, and I'm hearing more and more of this, are what they're calling quote unquote repurposed drugs. And we know that a drug is a compound that causes one or more things to happen in the body. And in many cases, they'll have one drug that's designed for a certain purpose, and then they'll discover, oh, wait, look at it, does this other thing. And
This is a little bit of a misnomer sometimes.
right.
Those drugs, the newer ones, have been tested to hit a certain genetic target that may be predominant in a certain kind of cancer, and so the FDA approves it for that kind of cancer.
Okay.
Other cancers can have the same target, and that's
Okay.
a new thing now. Okay, call it repurpose, whatever. Use it off label. Off label is maybe a better term.
There you go.
And okay, this was approved for breast cancer, but I have stomach cancer and it has the same marker, it has the same
Yeah.
gene mutation. I'm going to use it. So it's off label, but it's really still on target.
And do you see more of this happening?
I don't know. I'm not part of the oncology community,
Right.
but there was that big paper in Nature, whatever, a huge clinical trial showing you can find patients off label that benefit from these drugs because
Hmm.
they have the same target for which the drug was approved, but a different cancer. Who cares
Right.
what the cancer is? You have the
Right.
target. Use the
Yeah.
darn drug.
Agreed. Agreed. Well, and then,
That, and that's a good thing.
yeah. And even in a more extreme way, like Dr. Castro had prescribed to me an old flu drug that
Well,
he's,
that's really repurposing, but who knows?
yeah.
Why not? If it's not doesn't have a whole lot of side effects, let's give it a try.
Well, that was what he said. He says it's very, very, very safe. There's no side effects from it. And he said it can help to flip some of the switches on that will help your immune system recognize the cancer. And
Well,
I said, well, I took
it's
it
worth
for,
a try. Worth it. That kind of thing is, in my opinion, it's worth a try.
or even things like ivermectin, those are designed
Well, here you
for,
go. Of all the, resurrected type of drugs or repurposed drugs, it's got a lot of it's got a lot of potential, and people just have to forget all the politics that was associated with it before.
right, right,
It
right,
has nothing to do with nothing,
right.
and be open-minded. And we've seen some fantastic results of ivermectin in the dish. It zaps the cancer cells big time without zapping the normal cells. So that's really good. Can it do that in the human body? We don't know yet, but there's potential.
I love it. I think the next time we get on, I want to talk more about your experimentation methods and, we talk
Real
about
simple. The
in
real, real,
vitro.
real, real, real simple.
Yeah, but I mean, there's a lot of things people don't know anything about. You talk about in vitro, in vivo. You talk about different cultures and mediums, and what's
We'll,
simple
we'll,
to
we'll we'll go over it. It's
yeah. What's simple to you,
no
you're a
rocket
guy who's
science here, Joe. Real simple. We'll go over it. Happy to do it.
yeah, absolutely. Well, Robert, we've covered a lot of ground today, and again, my goal is to get people to realize. I keep coming back to the same answer though. when I think to myself, where would be the place to find the most up-to-date information about cancer? And I keep coming back to our Zoom call. Like, there is no other place in the world that you could meet with a team of experts the way that we do. It's maybe not the same people every time.
Chemo drugs. Boy, can we learn from them. And
Yes,
people taking the chemo drugs are doctors. Wow.
right. Exactly. And we have doctors doing, different things like vitamin C infusions and all the things Dr. Exume's doing. And
This vitamin C is not quackola. I mean,
no,
we saw the clinical trial coming out of Iowa. There's hundreds of patients, and they were all taking chemo for pancreatic cancer. And the arm that was getting the IV vitamin C lived twice as long. But
there you go.
they had to publish in some, journal that the oncologists don't read. They don't read that rag. It was called
Right.
Redox or something. They don't read that.
Yeah.
They don't read it, and they'll never read it. So
Wow.
it's how do they call it now? Under the radar or whatever.
Yeah.
Nobody's going to see it, but we put the word out.
Exactly. Exactly.
Put the word out to everybody. But
Well, it's available to everybody.
you save one man, you save a woman, you save the world. So we're helping people one by one, and there's no question in my mind that IV vitamin C, especially for these cancers that are just like, so, the doc says, you got one year or whatever. What do you got to lose?
I agree. I couldn't agree more. All right, Robert. Well, it's as always, this has been a fascinating conversation. I love getting into the weeds with you with this stuff, and I just want to thank you again. I
Well, I
consider
want to thank you. And we wouldn't have this conversation if we weren't talking to each other. So
exactly. Well, we make a good team. I'll tell you that.
we got a good team. We got a great team. And we have some terrific young doctors in our lab doing great work, leading the edge.
I love it. I love it. Well, I can't wait to hear the next stuff coming out of your lab, and
PubMed, a few new papers, Joe.
I love it. I love it.
PubMed to see the new ones, some good new ones.
I will be checking those out shortly. Thank you so much, Robert. It's always a pleasure to have you here.
Do anytime, just let me know. I'm always glad to be on your show.
Excellent. Well, this has been another edition of the Healthy Living Podcast. I want to thank all of our listeners for making this show possible, and we will see you next time. This has been another episode of the Healthy Living Podcast. We produce this show so that people can share their stories, people that have overcome obstacles, people that are undergoing obstacles. We're building a community of health-minded individuals. If you're interested in supporting the show, please leave a review on the platform you're listening to it on. If you're interested in becoming a guest, please send an email to itsjoegrumbine@gmail.com, or you can send a note into the notes section of the podcast. All right. Well, thank you for supporting this show, and we hope you've enjoyed it.